Dr. Bacharach, and he's going to be talking to us about crossing tibial lesions, wire-based approach, step by step.
Thanks, Mehdi. Thanks very much for being here and or for asking me to be here. These are my disclosures. So what I'm going to talk about, these are relatively basic, and I think some of these things will be in overlap, so you'll hear some of it, but it's really a crossing some tibial lesions and sort of a step-by-step. So this is more of a pragmatic approach. So you do have to understand a little bit about your lesion characteristics. The infrapopliteal lesions are often long and diffuse, which are a little bit different. There's often significant calcification. Segmental occlusions are frequent. And often there's collateral frilling that's noted with the disease extending into the outflow vessels of the foot. So there are some technical limitations. Specific below-knee devices and peripheral-specific stents or drug-eluting balloons are not yet routinely available. POBA remains kind of the mainstay for most of you and for most of us who do this. And the development of combined antegrade and retrograde approach has proved initial success. And I'll touch briefly in a little bit more basic fashion on what Dr. Lee very elegantly presented. So the approach, a targeted approach, requires optimal pre-imaging. So you need good DSA. You need to image the lower extremity and foot, typically in multiple views to demonstrate the best approach, and how collaterals are filling, because often that's really critical to your success. So you need to ask yourself, is the targeted lesion a stenosis or is it a total occlusion? How calcified is it? What's the length of the lesion? And which vessel is the optimal target? You heard about angiosomes. People have used that. Quite honestly, I've gotten to a point now pragmatically where I look at the vessel that I think is going to be the easiest to fix and that will provide the best perfusion to the foot. So the angiosome concept is a nice one theoretically, but from a practical standpoint, go for what you think is the meatiest artery that you can open that will improve blood flow. Now, specific balloon types, you need to know a little bit about what your inventory has. Access your inventory. Long balloons, including tapered, can be very useful. Scoring type balloons may improve outcomes, particularly in heavily calcified lesions. And so you just need to, and again, I'm not advocating any one specific type, but you need to know which balloons you have available. Now, wires, there's a confusing array of 14,000 wires that are available. You need to have a basic understanding of wire types, and it's really essential, along with understanding the type of tip and the weight. Is the core taper short or is it long? Penetration is more comprehensive than just the tip stiffness, and you need to understand the concept of wire escalation. And I think certainly for those of you who are doing CTOs in the coronary bed, there's a lot have been done. If you can look, there's some very elegant YouTube videos that Dr. Lombardi's done, for example. It gives you a big sense. And this is something that's relatively new to the peripheral world that we didn't spend a lot of time about. So with a tibial artery stenosis, well, how should you approach it? Start with a softer wire that's steerable and more forgiving. A long taper, it provides less support, but it often tracks better, especially through a long stenosis when you're not trying to bridge a total occlusion. Avoid having a support catheter or balloon too close. This tends to stiffen the tip. It increases the likelihood of a subintimal disruption, dissection, or even perforation of the vessel. Start with undersizing the balloon to avoid dissection. Again, a wide variety of wires are now available. Many are specifically designed for CTO. Be familiar with the types and find a few that you're comfortable with. Make that your workhorse wire. Be patient, go slowly, avoid dissecting the artery or potentially disrupting it. Alternative access, again, Dr. Lee did a very nice job. You know, clearly in the event that antegrade crossing is unsuccessful, consider pedal access with a retrograde approach. If its subintimal channel requires re-entry, it's best to be as proximal as you possibly can be in the tibial, rather that improves the likelihood of a more durable result, and it also allows you to do a bailout if you need to put, for example, a drug-eluting stent, coronary type stent in a more proximal vessel. That's clearly not something you're going to put in just above the ankle. Pedal access, which access, and I'm not going to belabor this, dorsalis pedis is easier, PT. The perineal can be very difficult, and I would reserve that for really more advanced, once you're more comfortable with your ultrasound and more comfortable with pedal access. So again, just some examples, pre and post. This was done antegrade, just basically trying to reestablish. In this case, it really was the posterior tib was the only vessel that we could reestablish into the foot. Here's a short segment occlusion, really of a tibial perineal trunk. You see the anterior tib, you see that short segment. This was actually, we used a coronary drug-eluting stent in this case to reestablish a posterior tib that allowed complete inflow. Again, here you have just a really high-grade stenosis with a single vessel runoff. This happens to be a perineal. And again, we're able to wire this from a antegrade approach. So this is a situation where we came retrograde, or pre-retrograde, we came antegrade. You can see long diffuse lesions in both the anterior tib and posterior tib with a little bit of filling of the perineal. This was one where we basically approached it antegrade, used a long tapered wire, were able to get through, and actually we balloon dilated both the posterior tib and the anterior tib, basically reestablishing flow into the foot. This was an initial attempt with where you can see the short segment occlusion of a posterior tibial artery that we were trying to establish to get flow all the way into the foot. This patient happened to have a heel ulcer that wasn't healing. You can see the other frame. You can see we're trying to come down from above. We can't get through. We're in a collateral. So it's so what we chose, we converted and came up actually from retrograde. You can see the wire coming up through a pedal access, and you see me steering the wire back into that small support catheter. And then we were able to wire that, and we now had a floss technique. We had a wire all the way through. We came now from above, ballooned it, and we were able to establish a posterior tibial. And you can see where we accessed it there, that actually filled, and we had excellent pressure actually at the posterior tib when we, so there are some current stent limitations. The ideal platform has not completely been identified or developed. The use of existing coronary drug-eluting platforms has only limited data. There is some data out there suggesting that they work. It lacks the specific design features that would make it more suitable for infrapopliteal and tibial use. Unfortunately, there's been really no randomized controlled data to establish optimal utilization. Again, my only advice is that if you have to do it more proximally in the tibial, don't try and put a stent down in around the ankle. In summary, it's critical to have optimal imaging and identify the optimal target that you're after. Plan the approach and know your inventory. Be aware of the devices and wires that are best suited for your intended target, and don't be reluctant to consider alternative access. And with that, I'll stop, and thank you very much for your attention.
Stay with us, Dr. Bacharach. Yeah, thank you so much.